So this is a patient who's undergone 2 long drug-eluting stents. This was about 7-8 years ago, and he came with a positive stress test. And here you can see that the stent is very patent, both in the LAD artery and in the circumflex. There is some slow flow in the diagonal branch, and otherwise the stent's absolutely patent. So he developed, these are metal stents, which are the drug-eluting stents. As I shown you in the previous patient with the soluble scaffold, now he's developed a new stenosis right in the mid-segment of a very dominant right coronary artery. Here you can see it's a dominant right coronary artery with a stenosis which is at the bend. So I crossed the stenosis with a BMW wire and dilated with a 2.5 balloon, and had to go to high pressures to remove the waste on the balloon, and then followed by deploying a stent. This is an alpine stent from Abbott. It's a 33 millimeter by 3.5 millimeter stent. That's the deployment of the stent. Had to go to high pressures to deploy the stent, and on a stent boost did a post dilatation with a 3.75 12 NC balloon, but had to go to 25 to 28 atmospheres, very high pressures, to open up the stent and oppose the arterial wall well. He had some stretching pain during the procedure. There was some slow flow in a RV branch which was treated with Nicoran. He's presently asymptomatic and better. This is the wire which has been removed, and that's the final result, with a very patent stent with no dissection, proximal or distal. No evidence of thrombosis. There's a TIMI3 flow. There's no distal perforation. There is some slow flow in the RV branch. He's been kept on nicorandil, which and now before we shift him to the ICU, he's perfectly asymptomatic and stable hemodynamically. So the idea of presenting this case is to show that so many years back I had put drug-eluting stents, 2 long stents in the LAD and 1 in the circumflex, and both are patent. And now with this new stenosis, again I put a drug-eluting stent, and it looks like an excellent result. Thank you.